This is Liz. This lecture is the second half of Chapter 40 on patients with special challenges. So this lecture will focus mainly on medical or traumatic conditions that have caused some type of loss of function in your patient. And we'll talk about a variety of challenges that can range from very mild to quite substantial. Here's just an example of some of the things we're going to talk about. We'll talk through some different types of sensory impairments, different cognitive and emotional impairments, paralysis, obesity, homelessness, poverty, and different types of abuse. So we'll start out with sensory impairment. And first we'll talk about hearing impairment. So this is something you'll learn to navigate quite well because it's very common in your older population, and obviously working EMS, you do encounter a lot of older patients, and a lot of these older patients do use hearing aids. Now that being said, of course, young patients certainly can have hearing loss. Infants can have hearing loss. So just be aware when you're communicating with patients to make sure they're able to hear you and able to communicate. Hearing loss can range anywhere from a partial hearing loss to complete deafness where they can't hear anything that you're saying. And the challenge for you in EMS is going to be how to communicate with these patients. You have your standard algorithm, and you want to ask things like, what happened, and work through your sample and ask about symptoms. And it can be really challenging when your patient can't hear you very well. So when you work with these patients, I think one key first is to make sure they even have their hearing aid if they use them. And quite often, just because of the nature of EMS, when you get there, these patients might not have it in because they might have just woken up. They might be, have been sleeping or doing something that didn't require usage of their hearing aid. So if you're having difficulty and you feel like you're yelling at a patient trying to communicate and they're not able to hear you, ask them, do you have a hearing aid? And sometimes they'll just be able to go get the hearing aid and your problem is fixed. And then another useful tip is just to make sure that you're enunciating well, you're talking slow enough that it's not making it difficult to understand, and your face is in view of the patient so they can see your lips move. And I think all of us will probably appreciate this one now that we have to wear masks. I mean, I'm sure every day you're like, wait, what did that person say? Because you can't look at their lips and coordinate it with what you're hearing to make sense of the sounds. And then if you really find that you just can't communicate verbally, try writing. There's nothing wrong with that. Your patient can write. You can write questions. They can nod yes or no. It's kind of a matter of being creative sometimes in how to communicate with people. And then lastly, make sure that if patients have hearing aids, if you notice them on the table next to the patient, but they're just not in, make sure they bring them to the hospital, because there's nothing more frustrating for a patient than being stuck in the hospital and not being able to hear what people are trying to say to you and not being able to communicate. So do your patient a favor, make sure you have any special medical equipment that they need, especially hearing aids, and bring it to the hospital with them. And same for glasses. Just as a side note, just make sure they have those when they leave out of respect for the patient. And then you might also, if a patient speaks sign language, I don't think most EMS agencies have video translators that you can use. If they do, that's fantastic. You can do that. If not, if they have family nearby, sometimes family can help translate. So use whatever resources are available. Okay, so vision impairment. A lot of things can cause vision impairment. These are just a handful of them, and we'll talk through them really quick. So glaucoma is caused by an abnormal increase in intraocular pressure, so the pressure within the eye, and then that pressure in turn damages the optic nerve, the nerve that's responsible for the patient's vision. So these patients first quite often lose their peripheral vision, so they can see just fine in the center, but they lose their peripheral vision, and then eventually it can lead to complete blindness. And then diabetic retinopathy, this is most common in older patients who've had diabetes for quite a while. And just the long-term effect of the disease is that it damages the small blood vessels in the eye. And then that in turn damages their vision, and that can also lead to complete blindness over time. And then cataracts, this one's actually easy for you to just observe in the patient, because this is when the patient's lens becomes cloudy. And you can see this, and if you do, just be aware that that cloudiness in their lens is likely affecting their vision. It can also affect your pupil assessment, cause you some difficulty in actually seeing the pupils. So any of these visual impairment causes can affect one or both eyes. Sometimes it can just affect one field of vision or a particular field of vision, and then some of these are reversible and some are permanent. For these patients, just make sure you're speaking clearly and loud enough for them to hear you, because they may, similar to wearing the mask, they may rely on, we often rely on watching people's lips, and these patients can't do that. So you just need to make sure you're talking slow enough and clear enough for them to understand you. And then if they can't see what you're doing, make sure that you're explaining everything before you do it. I'm gonna touch your arm. I'm gonna put a blood pressure cuff on your arm. I'm gonna start an IV. Or the paramedic. The paramedic's gonna start IV. Here's what you're going to feel. I'm gonna do an exam. Is it okay if I touch your belly? And just be very clear with your communication, because they'll be missing a lot of nonverbal cues that we rely on. And then if these patients need any assistance walking to the ambulance or getting their belongings, just make sure you help them out and ask, how can I help you? And quite often it's simply they'll hold onto your arm or they'll place a hand on your shoulder for guidance. But just talk to them, see what they need and see how you can help, and they'll tell you. So speech impairments, you'll see this in kiddos and adults. There's a variety of different types of speech impairments. Dysarthria is, these patients can produce the thoughts of words just fine. Like, there's nothing cognitively wrong with these patients. The problem is in the muscles that they need for speech. So these patients can't pronounce words correctly. They can't get the muscles in their mouth to work correctly to produce the speech. This can be young patients, might be born with difficulties. It also might be post-stroke. Some patients lose control of the muscles that they need to speak after a stroke. So just be patient with these people, because they know what they want to say. So give them time to work through it and try your best to communicate with them. And then voice production disorders. This is when just any illness or injury causes damage to all the supporting structures that are required for speech. So the larynx, the vocal cords, or any of the other surrounding structures. And these patients, again, can attempt verbal communication and they know what they want to say, but the sounds that they produce just might be a little bit off from what you're used to. They might be abnormally harsh, they might be a little hoarse or have an unusual pitch, or have some type of kind of nasal distortion that makes it difficult to understand. But again, similar to the dysarthria, just be patient, and then usually these patients can communicate. You just need to allow them to do so. Language disorders. This is a little more challenging because these patients have some impairment in their ability to understand the spoken word. So this isn't, usually you can't just wait this out and be patient, because these patients may not be able to understand what you're saying or may not be able to produce the speech. This can be due to congenital issues in children, if maybe they had a hearing deficit and they couldn't develop the spoken language, or had inadequate language stimulation early in life. Later in life, these can develop as a result of stroke, head trauma, or things like brain tumors as well. And then fluency disorders are disruptions in the speech patterns. So a really common example is a stutter. And we don't really fully understand what causes fluency disorders quite yet, but just be patient with these guys. And Let them, if they're having a stutter, don't rush them through it. Just let them get through what they're saying, and usually they can produce speech and you can communicate effectively. And I think in this picture, this patient is using a speech assistance device. And definitely, if patients have anything where they can point to a board, or they're typing, or they're using their eyes or their mouth to communicate via some other form, if they have a caregiver there, ask them, can I ask this? How do I do that? And be patient and try to work with whoever you're talking to, and through the way that they communicate. And you'll find that a lot of times you can communicate. It's just not the way that we're used to. Some other tips and pointers, if you're having difficulty communicating, and I think this is for any of the things we're talking about, don't ask super complicated, like multi-pronged questions, like, are you having pain? If so, where is it? What does it feel like? And does it radiate? Things like that aren't going to get you very far. So, and I think this is intuitive. Just ask yes or no questions, and work through them very methodically, and you'll get where you need to go. So we're going to talk about a pretty broad category of mental or emotional impairments. And these can range very widely from being so mild that you really can't even tell they're present, to significant enough that it's really impacting patient care, and you really need to adjust and take into consideration how to interact with the patient, communicate, and the impact it might have on their health. So first we'll talk about developmental disabilities. And these are typically present at birth, and sometimes they might not be diagnosed until later in life. So if you're dealing with a pretty young kid, they might not yet have been diagnosed with the developmental disability. They often involve the brain, and they impact the rate at which the person learns compared to their peers. Oftentimes the developmental disability can have already been present even in utero. It can occur at birth, or it can develop later after birth. Very common ones that you'll experience are Down syndrome, autism, fetal alcohol syndrome. Also, PKU is a common one, phenylketonuria. And there's a variety of endocrine syndromes as well that you could encounter. So these patients, again, there's a wide spectrum of how these present. There's definitely not a one-size-fits-all for learning about these patients. But some of the difficulties these patients can face are limited intelligence or a compromised ability to learn compared to their peers. They might have a speech impairment that makes it difficult for you to communicate with them, a behavioral disorder that also makes it difficult to interact. And sometimes you might actually be called for the behavioral episode. Sometimes they can be significant enough that parents have to call EMS to help. These patients might have language difficulties with communicating, and they might also have movement disorders. I think the best number one rule, and this applies to really any patient, is just treat these patients with respect. I think it's important not to make assumptions about their capabilities or their limitations, and rely on the people with them, their family members, their caretakers, and just be respectful and be kind. And I think my general approach is just to attempt to communicate and be kind, and see where you can get with communication. And a lot of times you'll be surprised at how well some patients can communicate. And then if you have a caretaker there's some really simple questions that can help you a lot. First I always try to say hi to the patient, ask their name, introduce myself to the patient, and if you're realizing that there's some type of barrier with communication, then ask the caretaker, can little Joey communicate, and how can I communicate? And they might say, well, he can understand what you're saying very well, but he can't produce speech. And that's important to know because, this is why even when you think patients can't understand you, it's so important to say, I'm going to touch you and take a blood pressure. I'm going to put this on your arm. I'm going to touch your belly. And communicate as you're doing things, because quite often the patient can understand even though they can't communicate back. And then also asking the caretaker things like, is he comfortable with touch? And they might tell you that, well, no, they have a lot of difficulty with touch, and it's one of their triggers. Or yeah, that's fine. And then just asking, is there anything I should know or anything I should avoid? I want to make sure they're comfortable. And it might be as simple as their caretaker saying, yeah, they really don't like bright lights, and then you can turn down the lights in the ambulance, or they really don't like loud noises, things like that. So just communicate, be open to working with the caregiver to really understand how you can best help these patients. All right, and then brain injured patients. These are patients that had some type of trauma to the brain. So usually, before the trauma, they had a normal cognitive state, and then they have deficits after the trauma. And this can affect, it can cause cognitive impairments, physical impairments, and emotional difficulties. This can be from trauma that happens at birth. It can be from child abuse, meningitis, infection, encephalitis, or some type of head injury. Cerebral palsy is pretty common, and it's a kind of catch-all term for motor impairments, and this is key, that it's motor impairments that result from some type of brain abnormalities, and sometimes it can be from hypoxia during birth. So I think the key for these patients is understanding that not all patients with cerebral palsy have mental impairment. They might, but that is not always the case. Sometimes they're completely mentally intact and cognitively intact. So make sure you're just treating all patients with respect, because you don't understand how well they can understand you. And even if they can't communicate well because they have the motor impairments, they might be able to understand everything that's going on and everything that you're saying. So they might have difficulty controlling muscle function. And often they are limited to a wheelchair and require a lot of assistance from a caretaker. They can have a lot of joint contractions, which means that their muscles are very tight, and a lot of times they have physical therapy to help loosen these up on a regular basis. But it can cause a lot of discomfort in these patients. And then brain trauma, of course, the deficits that these patients have can really range from very, very mild to very severe, and being reliant on a caretaker. They might have difficulties with speech, cognitive delays. They might be they can range from, to completely unresponsive to external stimuli and might be dependent on a ventilator. They might have feeding tubes for nutrition. They might require, day-to-day help with things like washing, turning in the bed, and changing the bed. So these patients fall anywhere in that spectrum from, you can't even tell they had a brain injury to completely dependent on a ventilator and unable to move, essentially. So for these patients, making sure you understand what their baseline, I think, is one of the most important things. And if someone calls EMS, you really need to make sure you tease out how were they before and why are you calling now? Because these patients might have a lot of medical problems, so you don't want to be confused and think, oh, I'm here because they're unresponsive, and the reality is they've been unresponsive since their brain injury. So a good way to ask the caretaker that is, what are they usually like, and what is their mental baseline? What is their physical baseline? And they'll help you kind of tease out what's new and what's an acute symptom versus one of their chronic medical problems. And some of the really common complications for these patients, if they have severe brain injury, is they're more prone to upper respiratory infection. Sometimes they just can't clear their secretions well. Maybe they have swallowing difficulties, and sometimes they can aspirate food. That can cause pneumonias. And then they have difficulty with nutrition regulation. Sometimes they might require feeding tubes. And bed sores can be a big problem for patients that can't roll over on their own and require someone to rotate them on a regular basis. All right, paralysis. So, your assessment and management of these patients is pretty much identical to that of any other patient, but one of the big concerns with these patients is really moving the patient from their bed or their wheelchair into your stretcher in the ambulance. And I think also just keeping in mind the specific complications that can face, medical complications these patients can have because of their paralysis. So there's two main categories, quadriplegia being paralysis of all four extremities. So these patients are paralyzed from their neck down. These patients are very often on a ventilator and also very often have to use a urinary catheter. Sometimes the urinary catheter will be in there 24/7, and other times they'll have a home health provider that will do what's called in and out catheterization, where like every 4 hours they put the catheter in, drain the bladder, and then remove it. That's a lower risk of infection. And then paraplegia is when patients are paralyzed from the waist down, and they might have full use of their upper extremities and can often communicate normally, can speak, and often can breathe just fine on their own. Patients with quadriplegia, they often have had a spinal injury in the vicinity of C3 to C5, or they could be suffering from some type of neuromuscular disease. ALS is one of those possibilities. And the only other thing I want to mention is when you're transferring these patients, be really mindful, even if they're not on a ventilator, be mindful of other devices they might have, like the urinary catheter when moving them, and work with their caregiver and ask them what the best way to transfer them to your stretcher is. Because they've often probably been through this before and they know what to be careful about, and you want to be respectful of that. These patients are susceptible to a lot of complications related to their paralysis. Similar to other patients we talked about today, they're susceptible to respiratory infections from aspiration and poor cough reflex. Urinary tract infections from their urinary catheters, difficulties with their feeding tubes. That can be infection, dislodgement, occlusion, and then pressure necrosis or bed sores, just from sitting in the same position and not being able to reposition as they need to. Again, the assessment and management in most ways is similar to other patients. And I think the key is just accommodating their special equipment and being aware when you're moving these patients. If they have a wheelchair, if you have a compartment in the ambulance where you can transport it, just go with your departmental policy. But, bringing their wheelchair to the hospital would be an excellent idea if you can do so. And then staying aware of their medical equipment, the ventilator, urinary catheters, ostomy bags, things like that. And then really involve the family members, the caregivers. They are the experts. They care for these patients every day. They know what these patients need. Just make sure you communicate with them, and they can really be a lifeline if you're not sure how to deal with things. Okay, so obesity. These patients, obesity, I guess first is just defined as 20% greater than ideal body weight. Morbid obesity being 50 to 100% greater than the ideal body weight. This is important to recognize because obesity is incredibly common. It can predispose patients to a lot of medical conditions such as coronary artery disease, diabetes, limited mobility, sleep apnea, hypertension. And all these things can come with medical complications that can cause these patients to require EMS. And I think it's important to remember that, obesity has a lot of causes. Some patients struggle with obesity because of physiological problems such as hypothyroidism, some medications, some psychiatric medications, seizure medications, things like that can also contribute to obesity, genetic problems, and then, increased caloric intake as well. these patients overall are classified as bariatric patients, and there's also can be some difficulties with transporting bariatric patients due to the limitations of the equipment. And there's most agencies either have or have access to bariatric trucks. Sometimes certain stretchers can't accommodate bariatric patients, and you also need to go ahead and call for a bariatric truck that will accommodate a bariatric patient. And I think a good point is that if you have to move an obese patient, this is when it's really useful to call extra resources. So this is when you call the fire department and you say, we need some extra help for lift assist, and they can send as many people as they need to go ahead and make sure you can safely move that patient onto the stretcher, not hurt yourself and not hurt the patient. Some special considerations also for obese patients is because of their anatomy and the extra adipose tissue and the weight on their chest and the adipose tissue around their neck, you have to just be mindful of the positioning of the patient for airway difficulties. If patients are quite obese, sometimes they can't lay flat because they can't breathe while laying flat. So just make sure you're asking these patients, what is the most comfortable position for you to be in? Do you want me to sit up the back of the stretcher? And oftentimes they'll say, yes, I'd like the back of the stretcher to be up at like a 45-degree angle so I can breathe better. Just keep an eye on their oxygen status, keep an eye on their ventilation status, and be mindful of their airway for sure. All right, so homelessness and poverty. You'll certainly be working with patients who are homeless and struggling with poverty in EMS. And this is very important because EMS is a safety net system for this population. A lot of these patients don't have access to primary care. They don't have a doctor that they can just call when they need an appointment or they can ask advice. They might not be able to afford these services. They might not have transportation to these services. So these patients really do depend on EMS. And it's important that you recognize the struggles facing these patients and you provide them with the best care that you can. It's easy to be judgmental, but you really have to remember that there are so many ways that people become homeless. People become homeless from unemployment, underemployment, substance abuse, general lack of affordable housing, mental illness can contribute. A lot of people become homeless after being released from prison into society without any resources. Some people have struggled with domestic violence and that has made them homeless, mortgage foreclosures, forced evictions, natural disasters. So there's just so many ways people become homeless, and it's just so important not to be judgmental and make assumptions about people. And then these patients really struggle with a lot of things that come with being homeless, and they're really susceptible to violence, whether that be interpersonal violence or just violence from general criminal activity. They can be discriminated against, certainly, for being homeless. They have reduced access to health care, and then increased health problems. It's really difficult to eat healthy, get good nutrition, take your medications when you're exposed to elements and don't have any resources. So these patients might struggle with general poor nutrition. You might be called for environmental exposure when it's really cold or really hot. A lot of the shelters will open up overnight with no maximum capacity on really, really cold nights, but we're talking below freezing, and there's a lot of reasons people don't want to go to homeless shelters, so they'll end up staying out in the conditions overnight. And they also struggle with lack of access to their medications, and then they're more susceptible to traumatic injuries. Again, just don't be judgmental, your assessment of these patients is largely the same as any other patient, as long as they don't have some type of other difficulty with mental and emotional or physical disability. Sometimes these patients will express concern to you over concern over the potential hospital bill they'll acquire. How much is this going to cost? Not having transportation. And unfortunately, you can't control the way the healthcare system bills. So the best thing you can do is just let them know of the resources available and educate yourself about what's available, and let them know that most hospitals do offer some type of financial assistance, though don't lie to them and tell them it's going to be free, because that's not the case unless you know that to be true in your area. And be aware of your local resources. If you know of a local shelter, local food banks, local free clinics, it's always helpful to let people know these resources, just so that once you deal with the acute problem, and if they go to the hospital, they'll have some resources when they leave the hospital. Shift gears a little bit to terminally ill patients. A terminally ill patient is just someone that's nearing their end of life, and death is anticipated within a shorter period of time, maybe 6 months. And a lot of these patients should be under the care of hospice. And I say should just because it's such a wonderful resource. And there's two types of care that you need to understand. The first being palliative care, which just means that the care that they're receiving is focused on their comfort and their quality of life rather than prolonging their life. So that means that the medicines they're taking aren't aimed to be curative medications. They're not long-term preventative medications. They're only medications that will provide the patient with more comfort and quality of life. And hospice is something that patients can enroll in or be eligible for once a physician has determined that their length of life is likely 6 months or less. It's incredibly difficult to estimate how long someone will live, but a physician has to say, this patient likely has 6 months or less to live. And then they can actually enroll in hospice, which is a wonderful service for people because they can receive home hospice care where a nurse will come in and they don't provide daily care for patients, but they'll come in 1 to 2 times a week and they'll check on the patient and make sure that they're staying comfortable. And then the patient and the family has access to the hospice hotline, which means a 24 access to a hospice nurse. And the benefit of this is if the patient's having discomfort or some type of acute episode at home, rather than having to call EMS every time, family can call the hospice care provider, and they can even come to the house in emergencies or give recommendations to the family. And your role in all of this is the most common thing I experienced was when things kind of go wrong at home. And that can come in a lot of ways, but sometimes when patients near the end of death, or the end of life, it doesn't go as family expects, or there might be an unexpected complication where the patient has pain or the patient has some type of scary symptom, and the patient and family just need someone there, sometimes for comfort, reassurance, and then sometimes they actually need some medical care. So let me go to the next slide. So again, you can be called when sometimes a medical crisis or near the end of life. And it's important to establish pretty quickly when you arrive on scene that a patient's under hospice care. Do they have a DNR? What are their wishes? And why are they calling you? What do they need you for? And sometimes it's going to be as simple as comforting the family. And I've certainly been called in the last moments of someone's life. And the only thing, the best thing that we could do for the family and what they really wanted was just someone to be there and to provide them with comfort and help them through it, because it can be scary for family. The other possibility is sometimes patients, even though they've said, I don't want, certain types of treatment and death is expected within a few months, there are still some things that can come up that they need treatment for. Sometimes it can be symptoms that the family just can't manage at home. Maybe their pain has become too much, they're having too much respiratory difficulty, and the medications that they're given through hospice are not adequate. In those cases, sometimes they can call the hospice nurse, and these patients can get inpatient hospice if they qualify, or it will just require that you transport them to the hospital to be stabilized, and then they can figure out where to go from there. So just because they're on hospice does not mean that they can't be transported to the hospital, but I think it's just always important to go ahead and unless there's something, if you have the time when you're on scene, go ahead and have the family call the hospice nurse and coordinate care with hospice, because they can be a wonderful resource for the family, and sometimes they can prevent unnecessary transport and unnecessary treatments. So your role when you're dealing with patients that are terminally ill, I think number one, you need to make sure you're providing emotional support to the patient and family. You're being kind and respectful. You're understanding the patient's and the family's intentions and wishes, and you're communicating with hospice if they're enrolled in hospice. And again, sometimes these patients just need comfort care or transport to the hospital for a problem that might not necessarily be related to their terminal illness. Hospice patients can still fall. They can still require stitches. They can break a bone. All the acute type things that anyone else can suffer, these patients can as well. And then make sure that you have their advance directives, you understand them, and you abide by them. But that's the end of this lecture. Thanks, everyone.